Contrast-enhanced transrectal ultrasound to monitor post-treatment recurrence after focal HIFU of prostate. Contrast-enhanced ultrasound utilizes ultrasound-enhancing agents as a contrast medium. Ultrasound-enhancing agents are microbubbles 2 to 6 microns in diameter. They are purely intravascular agents. Their safety has been demonstrated by a retrospective analysis of almost 80,000 studies reporting a severe adverse effect in 0.01% of patients, including suspected anaphylactoid reaction in 0.006%. FDA approval has been granted for use only in left ventricular obstruction, vesicoureteral reflux in pediatric patients, and in liver imaging. All other uses are off-label. Potential roles for CEUS in the management of prostate cancer include diagnosis, facilitating targeted prostate biopsy, real-time evaluation and confirmation of adequate tissue ablation after focal therapy, and identification of post-treatment recurrence during post-ablation surveillance. Our aim in this video is to present the role of CEUS in monitoring post-treatment recurrence after focal HIFU ablation of the prostate for prostate cancer. An ultrasound machine with a low mechanical index is used. 2.5 cc of Lumison is injected into the antecubital vein, and a 2-minute video clip is recorded over the area of interest. We would like to present 3 cases from our experience with CEUS. Our first case is of a male with a pre-HIFU PSA of 4.5 and a Gleason score of 3+4. A left hemi-HIFU was performed and his PSA nadir reached 1.12 at 6 months post-HIFU. He underwent follow-up biopsy twice, first at 1 year and the second at 2 years post-operatively, and was found to have no clinically significant prostate cancer recurrence. On his pre-HIFU MRI, a PIRADS3 lesion was detected in the left mid. 6 months later, the treated area showed no enhancement and no suspicious area on ADC and DWI as well. At his 2-year follow-up, the left lobe of the prostate had shrunk completely and no suspicious lesion was detected. On CEUS assessment, the images at 6 months and 2 years mirror the MRI findings. The MRI findings are very similar to the CEUS findings. On the 3-month post-HIFU CEUS, the treated area showed no enhancement. Case 2 is of a male with a pre-HIFU PSA of 9.1 and a Gleason score of 3+4. He underwent left hemi-HIFU. After 3 months, his PSA was 2.8, but it rose to 4.2 in 1 year. At his 6-month post-op assessment, CEUS showed an enhancing lesion in the ablated area in the left apex. At his 1-year follow-up, the patient returned to the clinic with a PSA of 4.2, and CEUS showed an even more evident enhancement pattern within the ablated area. At this point, at 1 year post-op, an MRI was performed showing apparent viability in the left apex. This was similar to findings on CEUS. The time intensity curves are depicted here. Before injection of the contrast agent, 3 regions of interest are identified prior to generating the curves. The blue box is a suspicious area, the yellow is the ablated area, and the red is a non-ablated area. The area in blue shows higher contrast uptake compared to the contralateral normal side in red and ablated area in yellow, denoting a suspicious result. In addition, when looking at the time intensity curves, the blue line has a higher amplitude and slope. Targeted biopsy from this area revealed Gleason score 3+4. The third case is of a male with a pre-HIFU PSA of 7. He had 4 Gleason score 3+4 cores from the left lobe and underwent left hemi-HIFU. PSA decreased to 3.6 5 months after HIFU, but increased to 4.4 at 14 months. 15 months after HIFU, MRI showed atrophy of the treated left lobe, but no focal lesions suspicious for high-grade tumor were identified. Transrectal color Doppler and CEUS showed a suspicious signal in the left lateral anterior area. Targeted biopsy from this area revealed a Gleason 3+4 lesion. we present our results of CEUS in the follow-up evaluation of focal HIFU for prostate cancer. 22 consecutive patients underwent primary focal hemigland HIFU ablation of the prostate and had follow-up CEUS, multiparametric MRI, and prostate biopsy. At baseline, median age was 65 and median PSA was 5.1. Median follow-up was 16 months and median reduction in PSA was 72%. At follow-up biopsy, Gleason grade 2 cancer was found in 4 cases and Gleason grade 3 cancer was detected in 1 case. In the 3 patients with in-field clinically significant prostate cancer, MRI detected 2 lesions and CEUS detected 2 lesions. However, the patients with lesions detected by MRI and CEUS were not the same. One patient had a lesion detected by both MRI and CEUS, one patient had a lesion detected by MRI only, and one patient had a lesion detected by CEUS only. Overall, among the patients with in-field clinically significant prostate cancer, 100% had lesions detected by either imaging modality. Each imaging modality was not perfect, but when both were used, 100% of biopsy-detected in-field clinically significant prostate cancers were detected by imaging. In conclusion, CEUS enhancement showed high correlation with clinically significant prostate cancer on follow-up biopsy in ablated areas of the prostate. CEUS and MRI were able to identify more clinically significant prostate cancer compared to MRI alone. The addition of CEUS to MRI can be helpful in the follow-up after focal HIFU. Additional studies and larger cohorts are needed to confirm our findings.
Great, thank you. I'd like to invite Dr. Abreu up for any questions from the audience.
Thank you, that was great. What is the perfect timing of scanning the prostate after injection of the substance?
So the protocol, you have everything in place, the patient has the IV line, you scan the prostate, then you have a sense where the lesion is, because you treated the patient, you know the MRI beforehand, you have all the mapping and everything. So on follow-up, you know the area that is more suspicious. Then we inject, when we find that the suspicious area, we inject the contrast in 20 seconds, it's visible on ultrasound already. So you inject, I inject 2.5, but you can rebolus as many as you want. It's very safe. And after this, you do 10 cc of saline. 20 seconds, it's visible on ultrasound already.
Stay on the lesion, you don't scan the entire prostate.
Now, this is, unfortunately, this is a limitation of these probes that we have. So we have a 2D probe, right? So when we inject, we can see the enhancing for that area that we are scanning. We don't see the enhancing for the rest of the prostate. So if the enhancing is happening on the other side, we don't see. If you have a 3D probe that you can scan in real time, then you acquire several images within very short period of time, then you can see actual enhancing from that specific area. Again, it's a limitation, but we are focusing on the area that is more suspicious.
There has been data looking at color Doppler and IV contrast, and static pictures of the color Doppler through the prostate can show vascular lesions. What were you actually using to show that black and white cine loop? That's just grayscale?
This is a very good question. I use multi-parametric ultrasound. I do grayscale, I do color Doppler, and I do contrast enhance. I'm just showing contrast enhance. Color Doppler is more used to
But you don't have the color Doppler on when you're doing the contrast enhance?
No. If you do this, you actually break the bubbles. So if you use color Doppler, the color Doppler break the bubbles. You have to use different modality. You have to have additional software to your machine to actually do the contrast enhance.
To capture the live image that you were capturing.
But the interesting is, if you are using only color Doppler, if I'm not mistaken, can see vessels up to 200 micron.
Yeah.
Okay, when you use contrast enhanced, you can see vessels up to 40 microns. So you see much smaller vessels. That's why color Doppler sometimes is not visualized and enhanced it is.
Anyone?
Andre, very, very nice images. Peter from Hong Kong. I'd just like to ask, is it possible to do immediate post-treatment CTRUS?
Yeah.
Yeah, to see if it's adequately treated, like, you know, after any modality.
That's why I started using. I'm showing only the follow-up, but I actually do pre-HIFU, immediate post-HIFU with the patient on the table to evaluate the efficacy and if I treated the specific area that I want, and I'm doing this for follow-up. Unfortunately, don't have so much data, you know, but we started doing HIFU 4 years ago. We have a reasonable number, but not enough to give you some good information. But yes, I use intraoperatively. And for example, when there is enhancing intraoperatively, after you finish your treatment, follow up this patient closely because he has a higher chance for recurrence. I'm saying overall experience without data. No, just do it right there. You see a very nice ablated data. This gives you a lot of reassuring and feedback. That's exactly why I started doing this, because I wanted to see what I treated. So I started doing contrast enhanced to see what I treated.
Thank you very much.
Thank you.